A 50-year-old man presents with polyuria, polydipsia, and serum sodium of 160 millimoles per liter. Urine osmolality is low. What is the most likely diagnosis? A. Diabetes mellitus. B. Syndrome of inappropriate ADH secretion. C. Central diabetes insipidus. D. Nephrogenic diabetes insipidus. E. Psychogenic polydipsia.
C is the answer. These findings indicate the kidneys are unable to concentrate urine despite elevated plasma osmolarity, pointing toward a defect in the antidiuretic hormone, or ADH, pathway, rather than a glucose-mediated osmotic diuresis. In diabetes mellitus, A, polyuria occurs due to osmotic diuresis from hyperglycemia, but serum sodium is typically low or normal, not markedly elevated, because of water loss accompanied by osmotic fluid shifts. Syndrome of inappropriate ADH secretion, SIADH, is characterized by hyponatremia and concentrated urine, the opposite of this presentation. Psychogenic polydipsia usually causes hyponatremia due to excessive water intake, not hypernatremia. The key differential diagnosis lies between central diabetes insipidus or nephrogenic diabetes insipidus. Both cause polyuria, polydipsia, hypernatremia, and dilute urine. In central diabetes insipidus, there is deficient secretion of ADH from the posterior pituitary, while in nephrogenic diabetes insipidus, the kidneys fail to respond to ADH. Although both present similarly, the question asks for the most likely diagnosis based on presentation alone. In the absence of a history of lithium use, chronic renal disease, or medications affecting renal concentrating ability, central diabetes insipidus is the more probable cause.
A 28-year-old woman presents with weight loss, tremors, palpitations, and a diffusely enlarged thyroid. She has atrial fibrillation on ECG. What is the most appropriate initial therapy? A. Propylthyrosol. B. Levothyroxine. C. Radioactive iodine ablation. D. Beta blocker. E. Thyroidectomy.
The presence of atrial fibrillation on ECG indicates that the thyrotoxicosis has led to cardiac complications, making immediate symptomatic control a priority. The most appropriate initial therapy is a beta blocker, D. Beta blockers, such as propranolol, are used to control the adrenergic symptoms of hyperthyroidism, including palpitations, tremors, anxiety, and tachyarrhythmias, and to help restore sinus rhythm, or at least control the ventricular rate in atrial fibrillation. They also have a minor inhibitory effect on the peripheral conversion of T4 to T3, the active thyroid hormone. Propylthyrosol, A, and other antithyroid drugs, for example, methimazole, are used to reduce thyroid hormone synthesis, but act slowly, taking several weeks to achieve euthyroidism, so they are not suitable for immediate stabilization. Levothyroxine, B, is used for hypothyroidism, not hyperthyroidism. Radioactive iodine ablation, C, and thyroidectomy, E, are definitive treatments, but both should be initiated only after the patient has been rendered euthyroid with medical therapy to prevent a thyroid storm, a life-threatening exacerbation of thyrotoxicosis.
A 60-year-old man develops sudden left-sided weakness and slurred speech. CT scan shows no hemorrhage. BP is 180 over 100 millimeters of mercury. What is the next step? A. Immediate thrombolysis. B. Lower BP aggressively. C. Start aspirin and monitor. D. Schedule carotid endarterectomy. E. Administer corticosteroids.
C is the answer. The case is classic indicator of an acute ischemic stroke. A CT scan shows no hemorrhage, confirming that the stroke is ischemic rather than hemorrhagic. His blood pressure is 180 over 100 millimeters of mercury, which is elevated, but still within the acceptable range during an acute ischemic episode, as mild hypertension helps maintain cerebral perfusion. In this situation, the most appropriate immediate management is to start aspirin therapy and closely monitor the patient's neurological and hemodynamic status carefully. Early administration of aspirin, 300 milligrams orally or via nasogastric tube, within 24 hours of symptom onset, after ruling out intracranial bleeding, significantly reduces the risk of early recurrent stroke and improves survival outcomes. Thrombolysis with alteplase could be considered only if the patient presents within the 4.5-hour therapeutic window and meets all eligibility criteria, but it is not automatically indicated without those details. Aggressive blood pressure reduction should be avoided because it can reduce cerebral perfusion and exacerbate ischemic injury. Carotid endarterectomy is a secondary preventative measure considered later. And corticosteroids have no proven benefit in stroke management. Therefore, the correct next step is to initiate aspirin and monitor the patient's neurological and hemodynamic status carefully.
A 30-year-old man develops progressive ascending weakness after diarrheal illness. CSF shows elevated protein with normal cells. What is treatment? A. IV immunoglobulin. B. Oral steroids. C. Supportive care only. D. Antiviral therapy. E. Plasma volume expanders.
A is the answer. It is a classic description of Guillain-Barré Syndrome, an acute, inflammatory, demyelinating polyneuropathy. The antecedent diarrheal illness is often caused by Campylobacter jejuni, which triggers an autoimmune response leading to demyelination of peripheral nerves. The CSF findings strongly supports the diagnosis of GBS. The treatment of choice for GBS is either intravenous immunoglobulin, IVIG, or plasmapheresis, plasma exchange, both of which have been shown to accelerate recovery by modulating the immune response. IVIG is often preferred due to its easier administration and lower complication rate, but both are equally effective if started early, ideally within the first 2 weeks of symptom onset. Oral steroids, option B, are ineffective and not recommended in GBS, as studies have shown no improvement in outcomes. Supportive care alone, option C, is insufficient since GBS can rapidly progress to respiratory failure and autonomic instability. However, supportive management, e.g. monitoring respiratory function, preventing deep vein thrombosis, and managing autonomic instability remains a critical adjunct. Antiviral therapy, option D, and plasma volume expanders, option E, have no role in GBS management.
A 45-year-old man presents with multiple silvery plaques with scale on elbows, knees, and scalp. Auspitz sign is positive. What is the diagnosis? A. Psoriasis vulgaris. B. Seborrheic dermatitis. C. Eczema. D. Tinea corporis. Or E. Lichen planus.
A is correct. These findings are characteristic of psoriasis vulgaris, the most common form of psoriasis. Psoriasis is a chronic autoimmune skin disorder resulting from hyperproliferation of keratinocytes and inflammation mediated by T cells, leading to thickened plaques with a silvery white scale and well-demarcated borders. The disease often affects extensor surfaces and may be associated with nail pitting or psoriatic arthritis. The positive Auspitz sign is a key diagnostic feature distinguishing psoriasis from other scaly dermatoses. It occurs due to dilated capillaries in the dermal papillae that become visible when the superficial scale is removed. In contrast, seborrheic dermatitis, B, typically presents with greasy, yellowish scales in seborrheic areas like the scalp, nasolabial folds, and upper chest, not thick, silvery plaques. Eczema or atopic dermatitis, C, causes itchy, inflamed patches with poorly defined borders and oozing or crusting, usually on flexural areas. Tinea corporis, D, a fungal infection, presents with annular lesions with central clearing and peripheral scaling, confirmed by KOH microscopy. Lichen planus, E manifests as violaceous, flat-topped pruritic papules, often on the wrists and oral mucosa, not silvery plaques.